Really excited for this conversation today about scaling innovation in California and how do we support access and equity in primary care through payment models. We have an incredible panel planned for you. I'm going to be your moderator. My name is Shruti Katari. I lead industry initiatives for Blue Shield of California. We're focused on scaling and sustaining healthcare innovation through industry collaboration and policy movement. So as you can see from our panel promo here, we have an exceptional panel planned, and we've really intentionally brought different national and local stakeholders here to discuss how California specifically can realize the vision for primary care as a common good set forth through the recent NASEM report. We'll be talking about that later with some of our panelists, but this is the Implementing High Quality Primary Care report. So Blue Shield of California has launched a pay-for-value hybrid payment model earlier this year. And we really do believe that the foundation to a healthy society is when we align around payment models that invest in care teams to improve people's health and instead of paying for services provided. So we hope the discussion today can be a stepping stone in that direction. And I mentioned our lovely panelists. So we have Chris Kohler, who is the president of Milbank Memorial Fund. We have Dr. Asif Bitan, who is from Ariadne Labs, Dr. Stella Safo from Just Equity for Health, and Dr. Sunita Mutha from UCSF. So Stella, Chris, Asif, Sunita, again, thank you so much for taking the time to be here with us today. You all bring tremendous experience and so much great examples that I know you are going to share in just a moment. But to kick us off, can each one of you introduce yourself and maybe just talk a little bit more about how you are strengthening primary care through the work you're doing around payment innovation? So maybe Stella, we'll start with you.
Hey everyone, my name is Stella Safo. I am an HIV primary care doctor based in New York. I see patients out of Mount Sinai Health System, and I have a healthcare improvement company called Just Equity for Health, which is the way that I'm hoping to contribute to primary care improvement and redesign. And that company has a three-part model, which uses advocacy, education, and care model design to think about what it means to actually operationalize equity in how we design and deliver our care for historically marginalized populations. A lot of that work really does involve thinking about what it looks like to bring people to the table who have historically been designed on rather than designed with. And so it is great to be here with you guys today because I think the background from various sectors, I've worked in industry, I've worked in health systems, is what is needed to be able to get us to where we eventually want to go. So it really is a pleasure to be here today.
My name is Asif Bitan. I'm the executive director of Ariadne Labs. We are a health systems innovation center based at the Harvard School of Public Health and also at Brigham and Women's Hospital, where I practice as a primary care physician in a community practice in Boston. I approach this from a variety of primary care centric perspectives. Of course, as a primary care clinician in a team-based practice, leading an organization, Ariadne Labs, which is really about finding no-do gaps, the gaps between what we know we should do and what actually happens in healthcare, and creating simple, effective, testable solutions, many of which are in the primary healthcare space. And we have a whole team that works on that, both domestically with community health centers as well as abroad. We are part of a global initiative called the Primary Healthcare Performance Initiative that was started in 2014 with the World Bank, the WHO, now includes UNICEF, the Gates Foundation, Global Fund, and others. And what we do is we've basically been able to create a global scorecard, a global mapping function for how we understand the effectiveness and availability of primary healthcare services and function, and then tie those to evidence-based practices for improvement in the landscape of large funders like the World Bank, the Gates Foundation, and others that can help governments in low and middle income countries improve their primary healthcare performance. The other part that I should mention of my work is as a senior policy advisor for primary care at the Center for Medicare and Medicaid Innovation, helping to design and test 3 very large comprehensive models of primary care payment and delivery: the Comprehensive Primary Care Program, CPCP, Plus and the Primary Care First program. And I am not speaking on behalf of CMS or CMMI today, but certainly those experiences will interplay into the discussion. And I was privileged to serve on the National Academies of Science, Engineering, and Medicine Improving Primary Care report, along with Chris and 18 other wonderful folks. Thank you.
Good morning, good afternoon to folks. I'm Chris Kohler, the president of the Milbank Memorial Fund. I want to start off by thanking Shruti and her colleagues for their leadership at their colleagues at Blue Shield for their leadership in kicking off this conversation. It's particularly important in California. The fund is a health policy foundation. Our mission is to improve population health by working with leaders and decision makers to connect them to the best evidence and experience. So we really are a policy shop. We think that policy creates the environment in which the health system works, and we think that policy change begins with leadership change. So we work on leadership programs, we work in specific areas, and then we publish with the Milbank Quarterly, which I hope people are familiar with, and our own fund reports. There clearly is a lot of evidence around the value of primary care for improving population health. And so we work with policy leaders to try to act on that evidence. This occurs mostly at the state level. We've been central and we hope catalytic around state level efforts to measure and improve the portion of dollars that go to primary care, as well as working with multi-payer primary care transformation programs, many of them the ones started by Medicare that Asaf was mentioning. I also do individual work. As Asaf mentioned, I was privileged to serve with him and 18 other folks on the National Academies report that we're going to talk about. And myself and also the fund works at the federal level as well to work with Medicare on the policies that they have to really create the environment that can make for a primary care oriented delivery system, which we think is essential to helping people live better and fuller lives. Thanks.
It's a pleasure to join you today. I am Sunita Mutha. I'm a primary care physician and a professor of medicine at the University of California, San Francisco, where I also lead Health Force Center. We are an entity with nearly 30 years of experience focusing on the people in healthcare. And for us, that means it's the entire gamut of individuals who contribute to the healthcare team, from medical assistants and community health workers to dentists, physicians, nurses. So we've had a long history of focusing on generating what the knowledge is around the workforce, who's in the workforce, what's the distribution, how are they prepared, what does the pipeline look like, to really also taking action, identifying ways of delivering care using this workforce. We do a lot of capacity building work, particularly leadership training programs that are across the state, and all of our work is in service of improving care. And so that means we are interested particularly in the equitable aspect of care. How does care serve communities? And the last piece that I'll add is that for the last 15 years or so, we've had a particular emphasis in looking at the safety net in California. So those are the perspectives I bring. And I should note that I don't speak on behalf of UCSF or the University of California system. So my opinions really reflect the work that Health Force Center has done and my own experience as a primary care clinician.
Let's go ahead and get started. So there has been several drops and mentions of the recent NASEM report on implementing high quality primary care, which was about the current state of primary care in the US. So Chris, I want to ask you, what is the status of primary care? Why is multi-payer alignment around payment specifically essential? And how does California fit into the national picture?
Thanks a lot, Shruti. I do think it's kind of ironic that you're asking the one non-clinician on the panel to start off with a definition of primary care, but I'll plunge ahead anyway because I'm a foundation executive. I think fundamental to the insights that the NASEM report put forth, they asked the fundamental question, is primary care a transaction or is it a relationship? And they answered that question. They're saying it's a relationship. If you think about what makes us healthy, what keeps us healthy, it's fundamentally relationships. It's not a series of transactions. So we defined high quality primary care as a relationship between the patient, the family, and the community, and a team of caregivers across all settings. We noted that primary care is causal for better health and more equity. There is nothing else in the healthcare system that can say that. Primary care causes better population health and more health equity. And as you noted in your intro, that makes it a common good. That's its preservation and development is of interest to everybody, and including the public policy to shepherd. We also noted that it is primary care in the US, in spite of this, its value is fragile and it's weakening. The portion of dollars going to primary care is decreasing over time. And that means that to implement high quality primary care, it's inherent for public policymakers, but also all players who are involved, providers, plans, consumers, to work in 5 areas to address. And you can read those in detail in the report, but the basic areas are payment, access, workforce, digital health, and accountability. We're not going to get there unless we have payers collaborating. If any payer thinks that they can transform primary care by themselves, and that is a fool's errand, and they're deceiving themselves and the people that they work with. This is just logic. If you look at economic forces and the portion of the population that any payer can control, and all you have to do is go talk to a primary care provider who is besieged by the policies and the payment practices of multiple payers, not only the big ones, Medicare, Medicaid, and commercial, but the payers, the administrators within each of those programs, the multiple Medicare Advantage players and the multiple Medicaid managed care folks, each of whom thinks they have their own strategy and their own payment strategy. Primary care providers and consumers are just saying, stop the madness. We need to get some collaboration, particularly as primary care becomes more fragmented, as we witness the CVS, what we'll call the CVSization of convenience care, the Med Advantage plans heading off to do what they want to do with a particular slice of patients. That's not going to work to really transform primary care. We're not going to innovate our way out of these problems. And finally, you asked about California. You guys are a country unto yourselves. You're the largest state, yet a third of your practices feared closure during COVID. And most of those practices, in spite of our efforts around payment reform, continue to be paid on a fee-for-service basis. California's had some really admirable work around cross-payer collaboration for quality measures and some purchaser alignment, but there's much more that needs to be done if we're going to transform primary care. You are a state that's participating in Primary Care First, the latest Medicare project. We need more payers to join on to that. And I would note that other states are leading the way. They're showing, just to the north of you in Oregon and Washington, they're showing how you can get payers on board sending the same signals to improve health equity. So there's a challenge here for California, but there's also a roadmap that it can follow. And I'm going to stop there and hear from our other speakers.
We would love the physician perspective. Asif, what is the vision for addressing health inequities and improving outcomes through strengthened primary care base? And why is this? We've heard about the status quo from Chris. Why is it so untenable right now?
Well, thanks for the question and the opportunity to be with you all. I would say I don't have the answer. I have an answer, and we have a wonderful range of perspectives on the panel as well as in the entire event. And I did notice, we don't have patients, and we have only a small number of advocates. And I think what we've learned certainly about primary care is that when done well, it is a community endeavor, and it takes all the stakeholders to really achieve its fundamental vision and dream. Now, what I'd like to talk about are sort of a few main points that really revolve around what primary care is and can be, what the relationship is between investing in primary care and achieving better health equity, and why, in order to do that, we have to elevate the role and position of primary care in our policy and payment environment, not as a charity case, not because we feel bad for primary care, or quite frankly, that you should even feel bad for the providers who are toiling away, although I think that is a consideration, if for no other reason I'm one of them. But it's actually out of self-interest. out of interest as payers, interest in common societal good, and interest in a healthcare system that has any hope of serving all of us and also maintaining its sustainability in any medium or long-term horizon. So to really pick up on what Chris said, and I really bring this perspective to you, not only from the US policy environment, not only from the microsystem level as a sort of primary care clinician and change agent, but really from the global macrosystem level. I'm going to just provide to you the following fact. There is no high-performing, effective, equitable, efficient healthcare system in the world that doesn't have an extremely strong base of primary care that's continually invested in and promoted and prioritized. There is no example. So if you're a payer and you say, well, we're here to build better payment systems that to deliver more efficient and better care for all, you cannot do it without investing in primary care. You can't. Now, you can pretend that you can do it. You can hope that you could create a new payment package and maybe it'll write the incentive structures. But I'm here to tell you a very key 50+ year historical and policy fact. If you ignore primary care, you ignore it at your peril, and you ignore it in a way that will not help you achieve your common goals. Now, let's be really clear. It's not such an easy thing that if you increase investments by a couple % in primary care, you will achieve magical outcomes, and especially in cost savings. They take time. Primary care is a time-based investment that's playing the long game. It's about thinking slow, not thinking fast. But if you're in the business of creating a system that actually serves all, is the first point of contact for the majority of health conditions, walks with patients and communities in their healthcare journey, provides continuity, provides coordination, provides a comprehensive mind, body, and community sense of who people are, as opposed to our current sick care system, which treats sick organs as opposed to whole people, then you have to invest in primary care. You have to do the first thing, which is the focus of our panel, which is invest in the fiscal space for primary care to happen. Now, COVID has made really clear that when you invest in primary care through a piecemeal, paying for small services, what happens is that you don't have the right investment modality, i.e. the form, and you don't have the right investment amount, i.e. the level, to ensure the availability of the common social good that you need to achieve an efficient, effective, equitable health system. As Chris said, the National Academies report is very clear. Only primary care is the segment of the healthcare system that regularly translates investments into equity outcomes. It doesn't mean that other stuff isn't important. Of course, we want hospitals, we want ERs, we want radiology. But if in the reckoning that has necessarily come to be in America about equity and the role of equity in health systems and the unconscionable injustice around equity, if you wish to address that, you cannot not address primary care. So that's why in the closing 30 seconds, the National Academies report found 3 big findings that I think are germane to today's discussion. We found that if you wish to create the fiscal space for primary care to just even continue and be able to maintain team-based equitable care, you have to pay for teams to build and maintain relationships, not doctors to deliver services by themselves. So you have to move away from this piecemeal coverage. Again, not a charity case, not ideology. This is fact. This is analysis. The second part is if you wish to get equity and better outcomes, you have to ensure that everyone has access to a usual source of care. And that revolves into a whole bunch of things we'll discuss today around how do you maintain that access. And the third part is in order to have access, you have to have a workforce. And that means you need to train people where communities are and where people live and work, not in only a few academic centers and then hope that they go back and spread out equitably to serve all. So I'm going to stop my comments there, and I'm so glad to be here with you all today.
Love it. Thank you, Asaf. That was very targeted. And want to continue that conversation. Stella, you're working to design models of primary care that has health equity as the central pillar of your approach. Can you talk a little bit more about that? And if you can provide any specific examples of your work and the central role of end users in redesigning care to address inequities to essentially kind of improve access and outcomes.
Absolutely. So I would start off by saying that from the health system's perspective, the goal really is to design a care model that allows patients to obtain care in an efficient manner and ensures payment. And sometimes we focus so much on that efficiency that we lose a portion of this that's very important, which is that patients sometimes are not involved in this design work, meaning that efforts may not meet the true needs of the population that we're trying to serve. And there are many care models that do come to mind that really offer examples of how you can focus on the important offerings, often of social determinants of health. You may be approaching a group that has diabetes and you think that the goal is to focus on the diabetes, but what you'll hear them say is, actually, I want to understand about getting and maintaining a job. I want to understand about healthy, living conditions. And so a lot of times what happens when you start to bring patient groups into the conversation is that there is an immediate kind of call to think about how your care delivery also includes addressing social determinants of health. One example is Oak Street in Chicago that has a model that offers non-medical services as a central part of its care. The entire clinic is actually built around a community center so that people in the neighborhood can come in whether they're patients or not. There are outreach vans that go out and engage individuals to come in for care, and this is following the idea of meeting people where they are. Obviously, this affects reimbursements because reimbursements are often tied to place of care. All of this is important because it centers patients around how the physical space is designed and also how patients are receiving care in the spaces that they need to receive care. And yet, if you think about how Oak Street was initially funded, this was VC backed. And it was one of the only ways that allowed the model to take off and to start to be tried in the way that it was tried. The same can be said for HIV care centers. And I work in HIV and have studied HIV, the history of kind of HIV care, and think a lot about it. And there's so much that we can learn from this. In the 1990s, HIV patient-centered medical homes took the perspective of addressing all the upstream needs for patients. So what did that mean? That meant that they provided peer support by hiring people living with HIV to work in the clinic. They paid providers to go into the community and offer testing and care to people who could not come into the clinic, again, reaching people where they are. They paid for a wide number of social work support staff who were dedicated to addressing social determinants of health needs for patients, such as employment, housing, job access, and also focusing on just overall wellness. And the HIV centers, again, wellness was a very, very big part of it. So they actually paid for services like acupuncture, massage, Reiki. Hadn't actually even heard of Reiki until I started working in one of my HIV centers. And the goal there was to engage patients to come in and then invite them to undergo testing and medical evaluation once they were engaged. And yet, like the Oak Street model, these HIV care models worked because in addition to, traditional funding from insurers, they also had government and private grants that allowed them to have some of these social service offerings. So we see that in each of these examples, there's unrestricted funding that is key, or there's just novel ways of providing funding that's key. And if you go back to the fee-for-service models that only pay for classic medical care delivery, these models that I've just described to you would not work. It's why current payments for population health really have to think about how we cover what I'll call some of the non-traditional portions of primary care delivery and what Asaf mentioned around team-based care, or hiring folks like community health workers or health coaches, doulas, others, investments in wellness, which is incredibly important for thinking about some of the psychosocial stressors that our patients are dealing with. And then ultimately hiring and training patients themselves who are affected by these chronic conditions, who can speak to and coach others with them much better than many of us who are providers can. And this last part, I think, is really important and comes to the center of what needs to be offered, because without insights from the people who live and know the disease in their local environments on a day-to-day basis, health systems are at risk of designing care models that just perpetuate inequities. And, part of the work of this conversation around equitable care model design is thinking about your patient stakeholders. And I come back to that again, because it often feels like the conversation with patient stakeholders is one that's just often had as a secondary thought. And the work that I do really centers this. One of the things that needs to happen is you start working with those that are impacted by the various, disease states or care models that are being designed, is that there has to be a conversation about historic, but also contemporary distrust of health systems around issues such as access or outright discrimination. Because without doing this work to address the historic and contemporary reality, design care models will just be seen as business as usual, and many individuals will not use them in the way that they're designed to be used. In addition, an equity lens sometimes actually requires health systems to prioritize certain groups that have historically not been prioritized as part of the healing and building trust and re-engagement. One example of this comes from a cardiac center in Brigham, where there was an effort to actually prioritize Black and Latinx patients to use the heart failure services. And so in this case, those patients went to the front of the line for admission to heart failure services. And making that clear, what that started to do was it started to increase community engagement with the Harvard system because strangely enough, many Black and Latinx residents who live in the kind of immediate area have tended to bypass some of the Harvard hospitals, which we know are some of the best in the world, to actually get care at other facilities that they felt more comfortable with. And so this is an example of, again, listening to that patient population and also designing care in a way that prioritizes some of their needs and starts to do the work of healing some of the historic mistrust. Finally, I'll offer some examples of how Just Equity for Health is doing this work going forward. So we are investing in advocacy in changing the top-down culture of medicine. And that really has focused on us thinking a lot about how we centralize the voices of frontline staff and patients. And then we're also thinking about how we're approaching care model design, itself. And in our work, we begin by acknowledging, again, that historic and contemporary inequities that impact the way that a given health system is perceived and has historically done its work. Then we look at the measures of success. And so many of us that are in the design space are thinking about classic pop health metrics like quality and utilization. And yet these may not be the things that are of importance to the end users that you're working with. They may care, again, about some of the upstream causes that are impacting their lives. And then finally, we have to start small before scaling. And with this, it's in part because the buy-in for equity work is always on very, very shaky ground. And without proving the kind of success of these smaller models, we stand the risk of losing some of that permissioning from the folks who fund and permission this work. And so these are just a few of the examples of approaches that we take as we do this work. And I would just remind us of the importance and the urgency of now, because without taking these approaches, we really are at risk of perpetuating the systemic inequities that affect so many aspects of our lives in the US.
You brought up so many amazing points. And I just want to highlight something in case it hasn't become clear yet to the audience. Every single person has touched on this, the importance of industry collaboration around this topic. So, Stella brought up just recently some case examples from innovative companies, but really it's whether you're traditionally a competitor within the healthcare ecosystem or a vendor relationship, whatever it is, this is really, really important and foundational industry collaboration to move this. And nothing has brought that up in our recent big events than COVID-19, right? Like we have come together as a healthcare ecosystem to get people to turn out, to get vaccinations, to abide by public health rules, whatever it is. And Sunitha, you are you've seen the firsthand impacts as a practicing physician for UCSF. So can you tell us a little bit more about why you think payment innovation is foundational to the issue of achieving high quality primary care? And also, what is the role of an expanded care team in specifically addressing inequities in both access and outcomes?
I want to say a +1 to everything that my fellow panelists have said. I couldn't agree more with the issues that have been raised. And so I'll focus my comments on the workforce piece of it and just talk a little bit about what the California experience has been, and my own experience, what it's been like. And what I can tell you is that, we talk a lot about something is in crisis. Well, California is in crisis when it comes to primary care. And what does that actually mean? Before COVID, we had 11 million Californians who lived in an area where there is a shortage of primary care. That was before COVID. That means 1 out of every 3 Californians lives in an area where there's a primary care shortage. And who is most affected? It's our most vulnerable patients who are most affected. So we're talking about the rural areas of California, the frontier areas of California, far north, our Central Valley, the less urban areas. But even in our urban areas, what COVID has done is it has shone a light on how much stress there is in this workforce. So we know anecdotally, because we don't have the data yet, we need more time for this, that 20% of the workforce is turning over in healthcare. And that's everyone. That is not limited to nurses or physicians. We are hearing early retirements, leaves, mental health leaves, and crisis like that. So take a workforce that was already available, under resourced, and amplify everything that the pandemic has done and how it's affected who is able to deliver care. And what that really means is, fundamental to this, the payment is what drives everything. And I'm oversimplifying it intentionally, but it drives access to care. It drives the ability to pay for care team members to provide care. So in my own practice, what we see is the care team consists not only of the clinicians or the physicians and nurse practitioners, it's our embedded social workers, it's people who are taking care of really ensuring that we're doing population-based care. And then it's, of course, all of the support staff that is needed to take care of the logistics, the approval for durable medical equipment, to authorizations and all of that. And so what we've seen in this time is that workforce has been really stressed, and payment matters. And so right now we continue to pay for clinicians to provide care. And when payment is tied to clinician services only, makes it incredibly hard in places like my practice and in places like federally qualified community health centers to actually provide the entire spectrum of care that primary care really does need to provide. And one of the consequences, and we haven't talked about this, is that their burnout has really increased, right? So most of us can say in the systems that we work in, 50% or more of the workforce has symptoms of burnout. And burnout matters because it affects the quality of care that we are all delivering. And so if you say that 50% of that workforce is burned out, that payment has the ability and realigning payment to really ensure that we pay for for a team to deliver care and not an individual to deliver care, and to get the flexibility that we need for where care is provided. The one great thing that has happened, a silver lining in the pandemic, has been that we have had lots of innovation. Telehealth has really expanded the ability to pay for electronic or e-visits, which some of the work that has happened in our practice, those things have been great innovations, and we need more of that, and we need that kind of investment. And I would say that, not having this, what does it do? It creates moral injury. And moral injury is when you know the right thing to do, you know what the evidence base is, but you are stymied by resources and policies that don't allow you to practice in the way the patient needs care and communities need care, as opposed to how payment and determined care will be delivered. So it's really an issue. I mean, so we have to have action now. We have to pay for a care team. We have to invest in primary care. There was points were already made earlier about the degree of underinvestment and the need for that. So we need to do that. And we have to allow flexibility in that payment. To take care of things like providing language access services. So in our practice, we have video medical interpreters, which are critical to ensure that our patients who have language barriers actually are able to get the best and highest quality care, which matters for equity and which matters for reducing disparities, whether it's in blood pressure or diabetes or any of our other chronic conditions. So I'll say more when it's time to go into our questions, but as you can tell, it matters for our workforce throughout the entire care team. And I look forward to being able to see better alignment.
Stella, Chris, Asif, Sunitha, I want to ask you your parting thoughts here on what would you say to the audience here today about why multi-payer alignment is essential and what can they do to help really support and achieve access and equitable care, essentially, in really create this primary care foundation we're all striving for.
I would say it's the central kind of inequities that have to be targeted. And what we are seeing is that we are asking health systems to do it. We're asking primary care to do it. And obviously it cannot happen with just a single payer or just a single health system or just a single service line. So there's a question that came up from Derek, who asked, how can we actually think about addressing the upstream causes of social determinants of health? And I think that gets very, very much to what you're describing, Shruti. I think we have to stop thinking about the short-term needs that are in front of us and start thinking long game. And if the long game is that your patient has diabetes because they live in a food desert, because they have no access to kind of further, opportunities or funds to be able to pay for the healthy foods that they need, I think what we as clinicians do is we treat the patient, we keep treating the patient, we work on getting payments for that patient and, reimburse the work that we're doing. And then we treat the next patient, we treat the next patient. There is work that's happening now, and I see it a lot. And this is why I bring up advocacy among clinicians who are saying, we're going to take this all the way up to the top. We're going to go to our elected officials. We're going to go to a conglomerate of healthcare, administrators, and we're going to say, the foundational causes for this are not going to be found within healthcare itself. Who else is working on this that can work with us to really start to think about what is driving all of this? And I love that COVID was invoked. All of us are tired of COVID. If we never say the word again, it'll be too soon. But COVID has really shown that if you try to solve a pandemic just within the healthcare spaces, and you're not thinking about policy, you're not thinking about economics, you're not thinking about social inequities, you will not solve it. And so, I would say that it's an excellent question for us to be asking, but it requires us to take one step kind of even farther up and say, what are these structural inequities that define the way that we live here in the States that need to be addressed? And how do providers and healthcare administrators show up and add their voices as those that see the downstream effects and say, we have to change this, otherwise nothing will ultimately change.
So, Shruti, I'm going to take up your challenge and speak directly to the payers. I do this as a recovering regulator. I was the Health Insurance Commission in Rhode Island. And I'm going to say, if you've taken the pledge, if you've been called on the carpet, you've taken the pledge to equity, and diversity, equity, inclusion, and all that great stuff. To Sunita's point, it begins and ends with payment. And you better have a primary care strategy and a payment strategy for equity if you're serious at all about this. And you better recognize that you're going to have to collaborate on that, because if you think you can do it on your own, you're smoking something. If you're not motivated by the altruistic notion, I'll get really practical. You're facing vertical integration in your provider delivery system. The health systems are gobbling up the primary care practices, and they're going to eat your lunch in your contract negotiations. You have a business interest to keep independence alive. And the other fact is that the bulk of your dollars are now public. It's Medicare and it's Medicaid, and they care about this stuff. And you better have a primary care strategy, because if you don't come forward with it, you're not going to get your business, or it's going to get shoved down your throats by a bunch of well-intentioned public policy regulators. So you can be altruistic or you can be practical, but I think payers really got to pay attention to primary care.
If I can I know we have lots of great questions, so I just want to make a quick point, premised again on, I'm not speaking for CMS or CMMI, but almost 10 years of experience in the CMMI multi-payer primary care payment reform world. Chris and Stella and Sunita talked about this fundamental fact. And if we leave you with a couple of points, I hear clear convergence on number one. This isn't a charity case. This isn't a nice to have. This isn't like we'll do it next Saturday once we've done our real business of the regular week. For all the reasons mentioned, this has to be front and center in your strategy if you have an equity and care improvement and efficiency play. Now, the key part of that is, let me just sort of bring it back to the microsystem level. I'm in a practice. I work in a team. If only one payer that encompasses 14% of attributed patients in our practice is paying for upregulated, team-based, IT-enabled, social determinants of health aware care that drives equity, and the other 86% aren't, and I've seen this over and over again in 15 years of policy work, then ask yourselves, how in the world can you drive that practice to do what we all wish it should and can, and we know it would do, were it not for the fact that 86% of its revenue is on a churning wheel, don't care about populations, just get the visits in model that totally is broken and COVID shattered. And telehealth adjustments and fee-for-service into telehealth aren't going to fix. So unless there is a multi-payer alignment, where everyone appropriately and within correct legal and FTC regulations gets together and says, yeah, we'll pay differently for a different, better, more community inclusive, equitable form of team-based primary care, you can't ask people to do the impossible with limited resources. And so it really is going to require the creativity and partnership in the multi-payer sector that, quite frankly, we haven't quite seen, even with 3 massive models encompassing 18 states and thousands of providers. We haven't seen that pick up yet. And I think that California is really poised to be a national leader if and when you can use this momentum and need that you have to sort of focus.
We haven't talked about the fact that when we pay for a care team, we are actually making progress towards a more equitable workforce, because that is where the greatest diversity in our workforce exists. It is among our medical assistants, our community health workers, our allied healthcare workers. So we have struggled as a nation to make progress in diversifying our most professionalized part of the workforce. But here is an opportunity, if we align payment with paying for the care team, for us to make rapid progress towards a more equitable, more representative, more diverse workforce. The second one, I will say on a personal level, we are now at a place where trying to get a primary care physician in an area like San Francisco that has had plenty of primary care physicians by the numbers, is like asking for favors. That should not be the case, that we should not be having to identify person by person who might possibly be accepting new patients, taking care of patients. And as people leave the workforce, which they are, my colleagues are, that means those who remain in the system continue to need to provide care for everyone else that we already have a responsibility for. So we have to work together to find a solution, because the destination of where this ends does not look good if we continue as we are.
Such great comments. We're going to move into Q&A. I'm looking at the time, but let's talk about something a little bit more tangible. I'm reading off of my phone from the questions you all submitted. How can payment innovation support a primary care workforce that's equipped to address cultural and language barriers faced by patients? So for anyone in the group.
I could start with this. So I think that there's a couple of things that we've touched on already. So as we have a more diverse workforce, and I mentioned who some of the members are of the care team, one of the advantages that often comes with that is they are not only bicultural, but they're bilingual. Not always, but often. And so that allows us an opportunity to increase access to our patients who have language barriers and have cultural influences that really impact how they use care, what is acceptable, and what their health outcomes are. So I think it's been, to me, this has been part of primary care, dating back more than 20 years, that language barriers are something we know quite a bit about. We have ways to mitigate those language barriers, and that costs resources to invest in. So I think that would be one of the ways I would say that we should be thinking about and addressing it, and how a more diverse workforce and access to those resources helps us mitigate and overcome those barriers.
We did get the doom and gloom question of what if we do nothing at all? What happens? So throw that back out there.
Well, I think that part of it you're seeing in the chat. We there are some anecdotal reports of people reverting back to fee-for-service. It's the devil. People know. People have been conditioned from their training programs that are overly focused on acute inpatient care with only, a month here, a month there, primary care, to then move into a fee-for-service kind of environment and just do their best. But, that is, sure, that could be where we go. I'm not one of the people who sort of continually predict the demise of my own field, but I have a hard time imagining that we will achieve our shared equity, improvement, engagement, and efficiency goals with, a workforce that's crumbling, that's based on, fee-for-service handouts. And, at the end of the day, ask yourselves a very basic question. And again, this gets down to dollars and cents. What gets seen gets moved. If you pay 3 to 5% of your healthcare spend dollar on primary care, that's not the priority. And primary care spending shouldn't be 40%. But in effective systems, it's 10 to 20%. And so if you're spending 97, 95% on acute sick care, high-tech, new drugs, radiology and imaging, that's what you're going to get. You shouldn't be surprised. You shouldn't wring your hands. Why are my costs going up? Because that's what you're spending your money on. And you shouldn't ask yourselves why you're not getting why your primary care infrastructure is crumbling, because it can't exist on fee-for-service crumbs. It doesn't work that way. If you want teams to take care of communities, they have to be paid in a prospective manner. We've estimated at least 60% of payments need to be in some perspective risk adjusted. And by the way, there's a question, hi Rishi, about social risk adjustment. Absolutely. It's a complicated field, but we have to be able to adjust in an equitable way to pay providers more for caring for patients who have greater challenges and who live in environments where there are more inequities, because that's harder, more intensive care. Now, will you recoup those savings back in 12 months? No. The National Academy report kind of dispensed with this mythology that you recoup investments in primary care because it's been starved for 40 years. You're not going to recoup it in 12 months or 24 months, but you can get to a cost neutral basis in 3 to 5 years. And more importantly, you can equilibrate what you need to equilibrate using, 4 areas. You need to change the level of funding in primary care. You need to change the form of funding. So moving away from fee-for-service toward prospective episode-based. You need to change the scope so that you're not just paying doctors, but you're paying for teams. So the scope of who's in and including community members in the team. And then you need to pay for, in an adjusted way, for better, more care for people who need more care. So that's just the reality of it. It's hard, but it's an inescapable reality. Chris, you look like you're about to say something. So
yeah, thanks. Shruti, to your question, what happens if we don't do anything? I think Sunita described it. It's a slow erosion. It doesn't mean that everything falls apart tomorrow. It's what California is experiencing right now in the environment. Slow erosion, more stress happening more frequently. And if we don't take this collective action, there are going to be some people who are going to do just fine. They're going to find a way to buy access. They're going to get their concierge services. But there are going to be more and more people who suffer. We're seeing it in Medicare fee-for-service. JAMA study came out last week, said that this is people with coverage, people with chronic conditions, the people we most want are reporting a decline, a steadily decreasing number of folks are reporting having access to a usual source of care. And that's people with insurance, with Medicare paying. And that's not cataclysmic, it's a slow erosion over time. And what I worry, that's why this equity focus is so important, because what happens is increasing inequity, which is what we're seeing in other places as well. The folks on the panel just happen to think that in healthcare, there are enough resources that we can make a stand against it. We can make the investments that are needed.
Last question. I think this is a great one and a great way to end our Q&A. What would you say to payers who are hesitant to invest in a big operational effort like payment innovation? So, to the payers on the line, what's kind of the last thing you might want to tell them before we wrap this up?
I would say look around. There are examples of newer and direct primary care models that have been using different types of payment models for some time. And so, I would say in the last 5 to 10 years, we have many of these examples that you can kind of rattle off. You can see where they've worked. Yes, many of them have been backed by VC funding, and yet there are parts of it that have really been examined and looked through to understand. And so you are not alone. We're not starting from scratch. And I think that it's an exciting time, because as folks are taking this step forward, groups like ours and others will really amplify your efforts. And if it's not successful, we will all learn from that. I think, as the other panelists have said, we don't have a choice. We have to walk forward. And so, please kind of take the chance, because we need all of us to be in this fight.
Shruti, what I would say is your purchasers and your regulators are your friends. Most health plans, when you come to them, know they want to put more money into primary care. I bet your colleagues at Blue Shield feel that, yes, they would love to give more money to Stella and Sunita and Asaf than what they're getting right now. They're hamstrung by their negotiations. So when we in Rhode Island told the payers that they had to put more money into primary care and non-fee-for-service mechanisms, the payers basically said, thank you. We needed the help standing up to the delivery system so that we could direct the money towards ways that we know is in society's benefits. So payers, to Stella's point, you're not alone. Actually tell your purchasers how they can help you do what you know is the right thing to do, which is to take these steps towards primary care.
One other thing that I think that you have built-in partners, because this will take lots of partnership, but there are built-in partners, particularly among those delivering care. We have to do things differently. And I think as we think about what these new models look like and how to innovate, just realize that part of the partnership exists in those who are delivering care. And this is an opportunity to actually be, I'm going to make this bold statement, to be on the right side of history, to do well by our populations, and particularly in California, where we have such a diverse population and such inequities, despite vastly expanded access to care since the Affordable Care Act has rolled out.
And I would just say, as you're making these decisions, I would just ask that you expand the aperture of the decision-making framework, the risk aperture, and also remember the counterfactual. So what do I mean by that? We're always looking, what's the evidence for making this decision? What's the evidence that I'll get my return? Yes, look for that. Engage in the wide variety of stakeholders, but remember this. There is grade A+ evidence that doing more of the same is only going to lead to further failure. And we forget the counterfactual at our own risk. So as you're evaluating, should we do this? Should we be bold? Should we work in a multi-payer framework? Should we take a big leap? I get it. Hard stuff. You're putting extra dollars. But ask yourselves, will doing more of the same change any format of this conversation and any reality on the ground that we've discussed for you? And if it is going to be more of the same, take the leap, take the chance, see what happens by doing differently.
Chris, really quickly, I'm going to just hand it to you to give some actionable items for the audience too.
Thanks, Shruti. I think where I want to close is just calls for 3 sets of actions, 3 sets of stakeholders. Plans come together now to enable this widespread adoption of population-based payment programs. You know what the right thing is to do. Find forums where you can collaborate, because you're not going to be able to do it by yourself. Providers and purchasers, you can increase pressure on the plans to do the right thing, to invest in primary care. Use your leverage, both as purchasers and also your political leverage as providers, to get them to do that. And then everybody on this call, and everybody's important, the consumers as well. You've got high functioning established coalitions, the California Quality Collaborative, the Integrated Healthcare Association, that you can join to support this kind of work. I'd encourage all of you to make new partnerships. We're not going to change things unless we take that risk to reach out to new folks, and to educate policymakers on the work that they have to do to kind of create the environment for these sorts of improvements to happen. California can do this stuff. You guys are very ambitious. You take on great challenges. You're the land of opportunity. This is the opportunity that we've got now. Thanks.